My name is Nicole Alonzo. I am a vascular surgeon at New York Presbyterian Brooklyn Methodist Hospital. I am also the chief of clinical research at Brooklyn Methodist Hospital. I had a patient who could not have TPA. The patient had a clotted AV fistula and graft. They needed a declot or else they would become catheter dependent. And I decided to try InThrill for AV grafts. InThrill requires 0 TPA to effectively get patients to be able to use their access for dialysis. And so that risk that we always worry about of an intracranial hemorrhage or bleeding from a surgical site, that's eliminated because we're not using TPA at all. Oftentimes with the balloon maceration technique, TPA has to break up acute clot, and sometimes it doesn't get that subacute clot. Well, the InThrill device has a nitinol core that mechanically disrupts even subacute clot. It's efficient. The procedure time on average is about 45 minutes. I've used it for over, I think it's now 80 patients with good success. They do dialysis the same day. Inari, as a company, is listening to its physicians. They have an engineering group that is always talking to the physicians to get feedback on how the devices are working. They're always innovating. Inari really does a good job of staying on top of things, listening to its clinicians, and making sure that patients are doing well. This is the Inari InThrill Thrombectomy Sheath. It is an 8 French system, which allows us to not only remove thrombus through the sheath, but also we can advance stents and do angioplasty of our AV access using the sheath. It has a hydrophilic outer element, which allows for easy use in patients who have grafts, and sometimes they have some scarring from repeated access attempts at the dialysis center. And then this is the InThrill thrombectomy catheter. It uses a nitinol core, which allows us to mechanically remove thrombus in fistulas and AV grafts. The patients that are undergoing thrombectomy with InThrill are patients with end-stage renal disease. Oftentimes they're admitted to the hospital for things that would lead to them having acute thrombosis of their AV grafts. And so in the setting of having an acute thrombosis, they need a thrombectomy to open up their grafts. InThrill is an option for them. The other patients that are undergoing thrombectomy with InThrill are the patients that I see in the office. I created their fistulas, I inserted their AV grafts, and sometimes their grafts will go down. We know that 22% of patients with AV grafts will have thrombosis in a 2-year period. I'll see them in the office and perform thrombectomy using the InThrill device on those patients. My interest in doing research in this area and my drive for it really originates from wanting to find the best ways to take care of patients. As a surgeon, we always have tools to fix a problem. It's really exciting when you see devices that are always innovating and helping us take care of patients more effectively. I've been involved in research for over 15 years. I performed 3 years of bench research at Dartmouth and then 4 years of medical outcomes research at Columbia University. Since that time, I've published over 50 peer-reviewed publications. 5 of the 50 publications that I've put out are from Inari. I've performed the first retrospective study looking at 13 patients that underwent 20 thrombectomies, and these patients were primarily patients who had multiple comorbidities that more or less prevented them from getting TPA. 95% of the patients in this study had AV grafts. In terms of our data, the average procedure time is 45 minutes. The blood loss is minimal at 10 cc's. Our primary patency rates are 77%, and our secondary and assisted patency was 100%. We have 100% technical success. They can undergo a procedure that is painless. In terms of complications, those are minimal, and 95% of patients are able to use the access same day. So with this device, clinicians will be able to remove thrombus in patients with fistulas and AV grafts. It's effective, it's minimally invasive, and it's safe. You don't use TPA, and so you're not worried about bleeding complications. And when my patients, when I see them in the office, they're still using the access. The lifeline of their fistula is more than 3 years now with this device. And so I'm excited to keep using it and seeing how far we can go in terms of maintaining access in patients who need dialysis.